That's the next panel discussion, which is on urothelial carcinoma, the perioperative setting regarding the NIAGARA trial. And the moderator is Dr. Amit Joshi, sir. He's a professor in medical oncology at TMH Mumbai. And our panelists consist of urologist, medical oncologist, and radiation oncologist. So Dr. Sasank Seni from TMH Varanasi, Dr. Lalit Agarwal, urologist from IMS BHU, Dr. Tushar Aditya Narayan from Euromax Delhi, and Dr. Akhil Kapoor, medical oncology from Varanasi, Dr. Amit Agarwal, he's from AIMS Raipur, Dr. Siddharth Starkar from Apollo Belapur, Dr. Ramana Murthy from Fortis Manesar, Dr. Rohit Swami from Narayana Hospital Jaipur, and from Dr. Gunjesh Singh from Paras Hospital Ranchi. So over to Dr. Amit sir.
Okay, Dr. Ramana and Dr. Vikas are not there, sir. Otherwise, all are there.
So I think are my slides visible?
Everything is fine, sir. You can go.
Yes. So I think we are already running a sort of time. So we'll just quickly start the discussion regarding the perioperative use. And we have a panel of medical. I think Dr. Sasank is from our teams, and Dr. Lee. So 3 neurosurgeon, and rest are all our med. And I think who are not there, Amit?
Dr. Ramana is not there, else everybody is there.
Okay, so we'll just have a quick discussion. So we'll start with our neurosurgeon, Dr. Sasank. So this is the usual presentation. This is the usual presentation of the patient, a 62-year-old male presented with a hypertension and presented with painless hematuria for 2 months. So, so how you will like to investigate a patient presenting with the hematuria? What are the initial investigations which you like quickly? Will you go for a USG or a front CECT tap? So how you will proceed in a patient of a painless hematuria for 2 months?
Good evening, sir. Sir, being a urologist and a uro-oncologist, in sitting in an oncology busy OPD, the answer will be straightforward: CACT tap, thorax, abdomen, pelvis. But from a urologist point of view, I would like to do ultrasound, maybe office ultrasound, to check for any clot, cytonephrosis. That's give idea how urgently I required a CT. A small bladder mass of 1.1 to 2 centimeter, maybe CT can be done, especially in the setting which we work, having long lines for the CT. In one line, it will be a CT thorax, abdomen, pelvis, a CT urogram, sir, for in these patients. And so maybe a urine examination also, sir, since the patient is having dysuria, just want to rule out any concurrent UTIs.
Okay, so if the patient has already done a USG and it shows
Yes,
the path that the usual way which we see our patients, so then we directly go for a further investigation.
Yes, sir.
So these are his lab reports. So in this scenario, that what we commonly this is the usual pattern we see, but rarely what happens that after going for a TURBT or we are not able to or a partial TURBT done outside by a general neurosurgeon, and now there is no lesion seen in that, and the histopathology is in this case these things are clear. So what are your indication for doing a re-TURBT in a case who has been diagnosed outside and not very sure about the muscle layer? So what are your indication for doing a TURBT in this setting?
Sir, we get quite a lot of this patient, what you told that outside TURBT has been done. We are not sure about the completeness of the TURBT. So the first scenario will be that only, which we are getting very frequently, that no reports or incomplete SBR with no documentation of the previous TURBT. We usually post that patient for a cystoscopy SS restage TURBT. Second will be from the books. As we know, any high-grade tumor, we should have a restage TURBT if the muscle is not found. And third will be, sir, in patients where we have a variant histology, a high-grade tumor, we are getting sarcoma or these variant. If if at all the outside report is also saying that complete, we doubly check the patient that it has been complete and maybe a restaged URBT, sir, in variants.
So I would like to ask Dr. Lalit. So in this patient, do you have see any role of FDG PET CT? Patient has done already a CT tap. Do you still want to advise for us a PET CT in this case?
Sir, we don't directly go for the PET CT. The histopathology report, I think it's high grade invading the detrusor layer, but the CT thorax and CCT abdomen has been done, and there is no metastasis. So we usually don't go for directly for PET scan. We go for the radical cystectomy in such scenarios.
So the other question comes where you fit the role of a MRI in this case. So
Yes.
the place of MRI, any specific clinical scenario
Right.
you want to do an MRI?
Usually in every patient nowadays, we go for MRI. Usually we are having many research projects on MRI. So
No,
to
for
grade
a
the
day-to-day, I'm not
Virats,
asking for a research project. For a day-to-day setting, CECT tap has been done. Is there any place of a MRI to look to the bladder? Any specific clinical situation where you can advise for a MRI?
if there is a contraindication to CT or if there is a diagnosis is not sure, then we go for MRI. Otherwise, MRI doesn't make a difference in management. Right.
Can I come in, please? This is Dr. Tushar here.
Yes, yes. So
Yes. So for answer to question MRI generally I reserve it for males if I have a suspicion of a concomitant prostate cancer also. So if I decide to whether I'll do a nerve spare or not, and for females for organ sparing cystectomy, if we plan a young female for whom we want to preserve the uterus, don't do an anterior exenteration, we routinely get an MRI done for females. And also, there's one particular situation, PT1 high grade, deep muscle present, and the patient is not willing for a restage TURBT because PT1 high grade is an indication for restage TURBT, even if muscle is present and free, and the patient is not willing. Then I sometimes get an MRI done just to make sure that there's nothing in the bladder.
The last indication which we read sometime that the urine showing a high, the cytology showing high grade urothelial carcinoma. The TURBT specimen has not shown the, or by repeatedly we are not able to get, and then we have to take a decision on radiologically. So MRI may have little bit as over the local staging, at least the T2 and beyonds